Respiratory Therapist Practice Exam 2026. Question 1. You have a patient who has just been admitted for a bronchoscopy. What are two specific parts of the chart you need to review? 1. Patient consent for procedure. 2. Patient demographics. 3. DNR status/advanced directives. 4. Religious affiliation. 1, 2, 2, 3, 1, 4, 1, 3. Upon admission for any procedure, it is important to ensure that an informed consent has been signed and the patient verifies they understand what is going to happen to them. DNR status/advanced directives are also important to verify as they will determine what actions will be taken if something were to happen to the patient during the procedure. Question 2. You have a stable patient who has been admitted for pneumonia. What is the important data to review on arrival to the floor? Orders, lab work, chest X-ray, pulse oximetry. The orders should be the first thing checked to be sure the patient is receiving the appropriate levels of oxygen and any treatments that need to be given immediately. The key word is stable. If the patient were in difficulty, it would be more important to check the oximetry first. Question 3. You are performing a clinical assessment on a patient. You have placed your hands on each side of the patient's chest wall. You feel bubbling beneath your hands. What is this called? Tactile fremitus, tactile rhonchi, crepitus, normal. Tactile rhonchi is felt through the skin as a rumble or bubbling feeling beneath the hands. Tactile fremitus is a palpable increase in vocal vibrations transmitted through the chest wall. The patient would say a word like 9 and the vibration would increase through the chest wall. Crepitus is a crackling feeling beneath the skin when your fingertips press on an area. A normal chest wall would have no feelings of bubbling, cracking or vibration with speech beneath your hands or fingers. Question 4. A patient comes into the ER with shortness of breath. What initial tests would not benefit this patient most? Pulse oximetry, cardiac monitor, CXR, breath sounds. The CXR will give you important information and should be obtained. However, the CXR takes time to order and to get the results back. When you have a patient arrive in the ER, you want to perform initial assessment procedures that take little time and give you valuable data almost immediately. Pulse oximetry, breath sounds in the cardiac monitor can give you vital information that gives you a baseline assessment of oxygen status, heart rhythm and breath sounds quickly. Question 5. What size ETT tube is used in a 30-week neonate? 2.5, 3.0, 3.5, 4.0. To determine the tube size, divide the gestational age by 10. This is the quick method to determine size. You can also select the uncuffed ET tube with an internal diameter of 2.5 mm tube for infants less than 1 kg weight, 3.5 mm for neonates up to 1 year of age. An internal diameter of 3.0 mm should be used for neonates over 3.5 kg and less than a year old. Question 6. A patient arrives in the emergency room with chest pain and shortness of breath. What questions are important to ask at this time? Past medical history, current medical history, smoking history, all the above. All the above. You need to determine if the patient has or had a history of cardiac issues, heart attacks, or some form of lung disorder. Smoking history will help to determine if they have a contributing factor to cardiac and lung disease. Question 7. What parameters are included in weaning a patient from the ventilator? RR 25 BPM, VT greater than 25 ml/kg, VC greater than 10 ml/k, minute ventilation 200. RR 50 BPM, VT greater than 30 ml/kg, VC greater than 12 ml/kg, minute ventilation 8 ml/k, RR greater than 20 BPM, VT greater than 15 ml/kg, VC 8 ml/kg, minute ventilation 10 ml/k, RR 20 ml/kg, VC 10 ml/kg, minute ventilation 12 ml/k. The criteria for RR, VT, VC, and minute ventilation have been determined through observation and study of the best techniques and parameters to obtain successful weaning. The standard weaning criteria, SWC, uses the respiratory muscle strength and endurance by using the negative inspiratory force, NIF, and positive expiratory pressure, PEP, to determine how well a patient will do when weaned from the ventilator. Question 8. A 2-year-old child is brought to an urgent care and diagnosed with epiglottitis. What symptoms were presented to get this diagnosis? Upper airway stridor, fever, dyspnea, all of the above. The symptoms in options A, B, and C are the most frequently seen in this scenario, as well as drooling, sitting forward, sweating. A neck X-ray will show a column of air around the epiglottis and a thumbs-up sign. Question 9. What is the newborn's normal IE ratio? 2:1 to 2:3, 1:1 to 2, 1:1.5 to 1:2, 1:1 to 1:2. The normal IE ratio for an infant with normal lung compliance and an infant with obstructive lung disease is the same, 1 to 1.5 to 1:2. An IE ratio of 1 to 1 IE ratio is used in infants with impaired dynamic compliance to ensure maximum alveolar recruitment. Question 10. You have a patient in sinus bradycardia. What are the 2 treatments you will choose for this patient initially? Lidocaine and pacemaker, oxygen and atropine, oxygen and digoxin, pacemaker and Inderal. Oxygen and atropine are the initial drugs of choice for the treatment of sinus bradycardia. If the bradycardia persists or devolves to a heart block, you may consider placing transthoracic pacing pads along with medication and oxygen. Question 11. You have a patient with a pulmonary embolism. What diagnostic study is preferred? Spiral/helical CT, angiogram, V/Q scan, CXR. A spiral/helical CT takes less than 30 minutes to complete. If you have an unstable patient, it is important to get the information you need quickly. The V/Q scan is considered the second best option. The CT angiogram is the last choice as it is expensive and takes longer to accomplish. Question 12. What values in pulmonary testing results will be higher than normal predicted values in obstructive lung disease? VT, RV, of, FRC, RV and TLC, VC, RV, TLC, FRC, TLV, RV. Obstructive lung disease will cause a higher than predicted increase in values of FRC, RV, and TLC. Obstructive lung disease causes an increase in chest expansion. Question 13. What is the best method to confirm tube placement? Breath sounds, capnography, bilateral chest expansion, oximetry. Capnography gives you the most immediate information. Breath sounds and bilateral chest expansion can be considered subjective. Oximetry is also a device that gives you data, but it is on oxygen, not end-tidal CO2. Question 14. Your patient has an ABG of pH 7.21, PCO2 56 mmHg, HCO3 23 milliequivalent/L. What does the ABG demonstrate? Uncompensated metabolic acidosis, uncompensated respiratory acidosis, partially compensated metabolic acidosis, partially compensated respiratory acidosis. This is an example of an uncompensated respiratory acidosis. The pH is acidic less than 7.35. PCO2 is high greater than 45 mmHg, demonstrated hypoventilation, and there is a normal HCO3. Question 15. What is the normal creatinine level? 0.5 to 1.0 mg/dl, 0.7 - 1.3 mg/dl, 0.1 to 2 mg/dl, 0.7 to 2.0 mg/dl. 0.7 to 1.3 mg/dl. Creatinine is a waste byproduct of the metabolizing of creatine phosphate, which is a result of the breakdown of skeletal muscle. There are 4 reasons why creatinine is used to determine kidney function. Question 16. You are looking at the orders for a patient to receive 125 mg of albuterol via duct HHNQ 4 hours. What is the first thing you do? Call provider and confirm the order. Give the medication as ordered. Give the correct dosage of medication and correct the order later. Skip the treatment. Patient safety always comes first. If the dosage is incorrect, you must call the provider and ask for clarification of the order. You do not give a medication order that is not correct. Question 17. What are the 5 parameters initially used to set up a ventilator? Tidal volume 6 to 8 ml/kg, RR 10 to 12 BPM, PC ventilation 35 cmH2O, FiO2 40 to 60%. Tidal volume 5 to 10 ml/kg, RR 20 BPM, AC/PC ventilation greater than 35 cmH2O, FiO2 50 to 100%. Tidal volume 6 to 8 ml/kg, RR 15 BPM, SIMV/PS 5, PEEP 5, FiO2 20 to 30%. None of the above. Tidal volume 6 to 8 ml/kg, 6 to 7 ml/kg is considered ideal, RR 10 to 12 BPM, PC ventilation 35 cmH2O, FiO2 40 to 60% are considered the standard protocol. Question 18. When weaning the patient from the ventilator, what parameters do you lower first? PEEP and FiO2. FiO2 and pressure support. PEEP and VT. FiO2 and VT. If your FiO2 is over 60% and your PEEP is over 5, lower the PEEP first. The reasoning is that if your P/F ratio PaO2/FiO2 cannot be maintained as you lower the PEEP, as you may have an underlying problem with ARDS. Question 19. How do you calculate compliance? Compliance equals change in pressure/change in flow. Compliance equals change in volume/change in flow. Compliance equals change in volume/change in pressure. Compliance equals change in pressure/change in volume. Compliance equals change in volume/change in pressure. Remember that the lungs are normally compliant. Question 20. Which of the following is not used to describe auto PEEP? Inadvertent PEEP, occult PEEP, breath stacking, stiff lung. The only name that is not used to describe auto PEEP is stiff lung. A non-compliant lung can contribute to auto PEEP occurring. Question 21. How do you fix auto PEEP? Increase the I time, give bronchodilator, suction airway and increase flow rate to decrease I time. Decrease E time and change to a square waveform. Decrease PEEP. Auto PEEP can be caused by secretions in the airway, too low a flow rate. By increasing the flow rate, you can decrease the I time. Question 22. How does PEEP adversely affect the body? Decrease of cardiac output and urine output. Decrease of lung volumes. Increase of blood pressure. Increases FiO2. Too high a level of PEEP can cause a decrease in cardiac output by decreasing venous return to the heart and decreases urine output. Question 23. If your patient is on a ventilator and the FiO2 is over 60%, but the patient remains hypoxic, what can you do? Increase the PEEP gradually. Increase the tidal volume. Increase the FiO2. Change the circuit. If the FiO2 is already 60% or over, then gradually increase the PEEP. Question 24. As dynamic compliance can vary at any point, what are 3 main reasons that dynamic compliance may be continually affected? Hyperventilation, water in tube, too long a circuit. Bronchoconstriction, kinked ETT, secretions. Secretions, FiO2 too high, PEEP too low. Atelectasis, coughing, sneezing. Bronchoconstriction, kinked ETT and secretions are 3 common, easy to fix issues that affect dynamic compliance. Question 25. You have a patient who has a brain injury. It is important to keep the airway pressures low to avoid increased intracranial pressures. What is the best action to take? Keep RR high, PIP below 30 cmH20. Keep FiO2. Keep PIP over 40 cmH2O and PaO2 over 60%. Keep RR low and PaCO2 levels under 20 mmHg and PIP over 30 cmH2O. Keep RR high to keep PaCO2 levels between 25 and 30 mmHg and PIP below 30 cmH2O to avoid suctioning and causing coughing, which raises ICP. Question 26. When giving acetylcysteine concentrations of 10 to 20%, how do you administer it? With a high-flow nebulizer. With NS 0.9% and then administer a bronchodilator. Administer a bronchodilator and then administer the acetylcysteine. With a filtered nebulizer. Administer acetylcysteine concentrations of 10 to 20% via a nebulizer after pre-treating the patient with a bronchodilator. Question 27. You have a neonate who is ventilated. The physician wishes to increase the MAP. What two settings do you change? VT and flow. I time and VT, increase I time and pressure limit and flow. Increasing the I time increases the time the flow is entering the lungs, which will increase the airway pressure. Increasing the pressure limit allows for the increase in MAP. Question 28. A patient who is on nebulizers at home states that the nebulizer is no longer working. What can you do to help the patient? Change the patient's therapy to an MDI with a spacer. Tell the patient you will both need to talk with the caseworker and get help with getting a new nebulizer. Tell the patient they will need a new nebulizer. Speak to the physician about changing the patient's therapy to an MDI with a spacer. When a patient's equipment is broken, it is important to have both of you speak to the patient's case manager to arrange procuring a new one for home use. Question 29. How does a patient disinfect home equipment? Water and hydrogen peroxide cleanse with a brush. Acetic acid soak for 20 minutes. Steam or boil equipment. Diluted bleach. Acetic acid soak for 20 minutes. Question 30. The patient is receiving bronchial hygiene therapy. What are the symptoms that would cause you to discontinue therapy? Nausea, vomiting, shortness of breath, headache, tachypnea, fever, cyanosis, dizziness, increased work of breathing. None of the above. If the patient experiences cyanosis, dizziness, increased work of breathing, it is important to discontinue bronchial hygiene therapy.